All right, folks. Wanted to talk to you today about Chapter 8, Part B. We just went through Chapter 8, Part A, which it concerns general joints of the body. And now what I want to talk about is get a little bit more specific into joints. And that's really what Part B is all about. So again, when we look at joints in particular, what I want to concentrate on in Part B is looking at synovial joints, right? So again, synovial joints are pretty diverse. When we talked through Chapter 8 here, Part A, we talked about synovial joints and how vast a diversity there is. And there really is, because there's a lot of different synovial joints. Again, you have to reference back to the figure in your book to look at all the joints that are found in the body, and in fact, their function as well, right? And so what I want to really look at in particular for Part B, and we can make this really short because I really want to focus on one particular type of synovial joint, and that's going to be the knee. Because the knee is so diverse and does a lot for us, I really wanted to focus on that one. We will talk about the other 5 synovial joints here, but I really want to discuss then the knee, right? And so I really want to begin talking about the knee in discussing a clinical case study, and really talking about knee injuries, right? And so when we talk about knee injuries, we know that there is a lot that exists out there. There's going to be a lot in your clinical career later on demonstrating these different types of knee injuries, and you're going to see a vast variety of these, okay? And so the knee, in fact, the knee joint, knee synovial joint, absorbs a lot of different types of force, right? And so there's a lot of vertical force, and what we mean by that is if this was your kneecap, in fact, forces that go up and down, or from the top down, the knee absorbs that a lot, right? So it can actually minimize those, and you don't see a lot of injuries from the knee down. So if, for example, jumping from a high level, maybe a high, roof, for example, jumping down on your knee can absorb, for the most part, a lot of that force from the top and the bottom. But when we discuss really and looking at, when we look at knee injuries that come horizontally is what really we discuss and what we see a lot of injuries coming from, right? So horizontal blows that come from the left side of the knee or the right side of the knee is where we really get a lot of injuries. And so when we take a look at knee injuries, usually common knee injuries involve what we call the 3 C's, right? Right, the 3 C's. And what are the 3 C's, right? The injuries that involve the collateral ligaments, the injuries that involve the cruciate ligaments, and then injuries that involve the cartilages, right? And in particular, if you notice, this is the menisci, right? The special type of additive feature that some synovial joints have, and the knee joints, in fact, have this as well, right? And so when we look at a knee itself, and we look at, for example, lateral blows, we can see, for example, where the collateral ligament is, where the anterior cruciate ligament is, and where the medial meniscus is, right? And so when we look at that, and we'll take a look at this in just a second, of an example that we see that we call the unhappy triad, right? So this is actually a clinical label for what we see here, right? The unhappy triad. And what do we see with the unhappy triad, right? Collateral ligament gets damaged, the meniscus gets damaged, and a cruciate ligament gets damaged. Okay? So let's take a look at those, right? The collateral ligament is going to be this ligament found right alongside the knee, right? So if you look at this one, you see this tear right here in particular. That is the tibial collateral ligament, right? Tibial collateral ligament. And so we see a ligament that joins, for example, this part of the femur to this part of the tibia. And we see that joining, if you will, becoming the collateral ligament. And then we see the pulling, if you will. You see that, and if you notice the force getting applied this way and this way, okay, causing this collateral ligament to stretch so much that exceeds the force that holds it together and causes a tear, right? So that's one part of the unhappy triad, right? Number two of the unhappy triad we see is the medial meniscus, right? So this menisci is actually found right here in the middle of the knee, right? In between the, again, femur tibia and fibula, right? So those three bones and that joint, you've got this medial meniscus here, and what's causing, again, the pulling, if you will, is the force applied from the hockey puck going this way, right? Causing then the tearing, if you will, of the menisci right in this area. Okay? So that's number two. And the number three of the triad means three, right, is the anterior cruciate ligament. And this is a ligament found in the middle of the knee, per se, but kind of found right here at the posterior side. And this is not, we're, you know, the asterisk pointing or distinguishing the anterior side, but actually the junction, the origin of the ligament, if you will, is actually found on the posterior side. And it comes right and joins right there, attaches the ligament right there. And in fact, the pulling, the force, again, applied by the hockey puck here that we see, again, causes then that, the force to overcome there and cause a tearing of the ligament, right? All three are what we call the unhappy triad, right? And again, what's the susceptibility? Not necessarily the force applied vertically, either this way or this way. It's actually force applied this way, right? Or, I'm running out of room here, this way, right? Horizontal, right? So horizontal force is usually what we see in knee injuries, right? Okay. So taking a look at cartilage tears, right? Cartilage tears are usually because of one or two types of injuries, right? They're usually going to be from compression, right? Compression or shear stress, right? Compression or shear stress. So what do we talk about when we talk about compression? So if I was to draw a piece of cartilage here and draw some arrows, the arrows represent compression, right? Squeezing, if you will, right? Compressing the tissue down so much, or the cartilage so much, that we cause a rupture, sometimes breaking out, okay, of the cartilage, right? That's a compression. And what about stress, right? So if I drew another piece of cartilage here, and then I draw the force applied, right? One force goes this way, and the other force pulls it this way. And so by what we see here of pulling, if you will, can cause then shear stress. It's like taking a piece of paper, if you will, and then tearing that piece of paper in half, right? One hand goes down, one hand goes up, or one hand goes left and one hand goes right, and we tear the paper, and that's what we know to be shear stress, right? So cartilage damage can result from either compression, the force applied from the top or bottom, and shear stress, right? And what we see here, just kind of going back, when we see the menisci there, that menisci there is really because of shear stress. Okay. So the issue with these is that cartilage, again, rarely repairs itself, right? Has a tough time repairing itself. And why is cartilage tough to repair? Because cartilage is what? Avascular, right? Which means what to everybody? No blood vessels, right? We don't have any blood vessels. We can't bring the nutrients, healing properties, repair the cartilage itself, and we cannot get out of that waste. And because of that, cartilage tends to actually scar up. So scar tissue forms in replacing of the damaged cartilage. And we see that occurring. So because there's no blood, again, we can't heal. And again, cartilage forms scarring or doesn't heal completely. Okay. We usually use arthroscopic surgery, and that's a technique that has now been introduced in the past 30 years in the terms of actually not opening up the knee completely from femur to below to tibia and opening up the skin through a incision, but actually making slight tears, like slight incisions and slight small incisions, usually 4 to 5, and then using devices to actually repair inside the knee. So it minimizes the extra trauma of the knee, right? Okay, so this is really quite interesting to look at, but these talking about arthroscopic surgery and looking at these pictures, you know, these devices that they can use, they actually have optic cameras in there, and they can actually see the interior part of the knee and repair any of these portions, right? So just draw a line here and go up, and that's all femur there, right? And then if we draw a line down here, this is all tibia there. And if you look right here, all this here is actually menisci, right? All of this tissue here and here and here is all menisci. Now notice, if you will, the white portion right about here, okay, in that area. If you notice, that white portion right there is actually the tear in the menisci. It's actually where we have a tear of the menisci, like that, okay, from shear stress pulling, if you will, the menisci and tearing it completely open, right? And they would go in there and actually suture this, much like what I did with the pin here, suture this together, and then suture those incisions that they stick these cameras into, and then it heals much faster, believe it or not. Okay, so what is a sprain? Okay, it's either a ligament gets overstretched or a ligament gets torn. So in fact, some of those knee injuries that we just saw here with ligaments are actually sprains, right? And we can actually look at sprains and we can judge them and decree them based on the degree of its sprain, right? So again, first, second, third, sometimes there's a fourth degree of sprain. Talks about then how much tissue damage there is, how much stretching there is, and how much tearing there is. And as far as the number, when you increase the number, you increase the damage, right? So there's more damage the higher the number, right? So what are some of the common sites, right? The ankle, number 1, the knee, number 2, and the lumbar region of the back, right? That's the small of the back, right? So if you were to look at a side view of a back, right? You got the neck here, and then you got this area here, kind of snakes around this way, right? And we would call this the cervical, the thoracic, the lumbar, and the sacral, right? So again, the curvature of the back, and again, this is not drawn to scale. You know, this line isn't perfect, but that's really what the regions are at, right? And so the one that we're looking at that we see the most damage here in sprains is this lower small of the back, right? Right above the buttocks, right? And that's what we see, the lumbar area. Now that's a susceptible area of the backbone, and so we see a lot of pulling either, let me change the color here, pulling either this way, okay, or pulling either in this direction, causing that spine to be out of alignment, causing some of the ligaments that hold the spine in alignment to be either stretched or torn, right? So this is commonly what happens when, for example, somebody lifts without using their legs and wants to use their back. The common area that gets damaged or torn or stretched is the lumbar area, right? And again, just like cartilage, repairs very slowly, poor vascularization, right? You know, that tissue doesn't have too much blood vessels feeding it, and because of that, we have poor vascularization and poor healing, right? Poor repair. Okay? All right, so luxations are actually dislocations. This is where bones are forced out of alignment, okay? You usually have sprains that accompany with it, so if you're going to have a dislocation, almost always you're going to have a sprain, a ligament that's either torn or pulled, stretched beyond its limit. And anytime you have that, those conditions, inflammation will usually set in. And part of inflammation is swelling. Swelling to that area causes the immovability, right? Immovability. So you become immobile, right? The joint does not move like it normally is, right? So all of that is accompanying with dislocation, right? Usually what we see most commonly in dislocations are because of a fall, and we see a lot of them in sports, right? A lot of trauma to the body with a lot of force causes these bones to go out of alignment. All right. Okay. Bursitis, and we talked about this in part A, but this is the inflammation of the bursa, right? The bursa. Usually it's because of friction or trauma, but as I mentioned, we also have overuse, right? Overuse of the joint, right? And I mentioned as an example, if you know, don't use, if you're not accompanied or accustomed to undergoing manual labor, and then you decide that you want to start, you know, first from one day to the next, start manual labor, you know, those type of overuse types of jobs or movements can cause bursitis as well. But again, the inflammation of that little bag, right, little bag of fluid found between bones, if you will, in these joints is what we call bursitis, right? Okay. Tendonitis is the inflammation of the tendon sheaths. So think of tendonitis and tendon sheaths, and we talked about that, how those types of bursa cover tendons that are points of attachment to bone or skin or what have you, right? And this is usually because of, again, overuse as well. So let's talk about arthritis, right? Arthritis is one of the biggest types of you know, conditions that we see in joints, right? And believe it or not, there's at least 100 or more different types of arthritis, right? And arthritis is very much of a inflammatory type of disease, and usually it's because of inflammation, high inflammation of the joints, and that inflammation over time causes degeneration, right? So it causes then damage enough to the joints to where they become those joints aren't functioning correctly anymore, right? So it's very much of a cascade, right? Inflammation again leads to degeneration, and that then becomes immobility, right? Again, what are the symptoms here? Pain, stiffness, swelling of the joint. We see these occurring in arthritis, right? In acute forms, right? Short term, okay? Very rapid onset of arthritis, and then the rapid, you know, relieving of arthritis. It's usually caused by bacterial. Bacterial infections can actually cause then acute arthritis. And then the chronic ones are the ones we have to really be careful with, right? And so there's three main ones we're going to talk about here: osteoarthritis, rheumatoid arthritis, and what we call gouty arthritis. Osteoarthritis is the most common type of arthritis. Okay, the most common type. And it's irreversible, right? So osteoarthritis is irreversible. And it's usually because of wear and tear, right? So we use the word wear and tear because this is usually where we're going to talk about picking up, using our joints over time, so much so that they become worn down, right? They wear themselves down, and then they become less functional, right? So just a quick statistic here: by 85, half of the Americans, right? One half of the Americans develop osteoarthritis, right? It's more common in women than men, and this really has to do with different hormone levels, right? Between male and female, right? And because there's a different hormone levels here, we see then more damage to joints in the form of osteoarthritis in women more than men. Right? So again, osteoarthritis is part of the normal aging process for the most part. Okay. We see this occurring. Stiffness of the joints, crunching noises. Call this crepitus, by the way. Don't need to know this for an exam, but crepitus is what we hear, that crunching noise, if you will. And again, degeneration, right? They're generating conditions, right? Slowly these joints are becoming immobile, right? All right, our next one is rheumatoid arthritis, or RA, right? RA. And this is very chronic, so this one is a long-lasting, right? Very long-term type of disease. And it's actually an autoimmune disease. Okay. And what does an autoimmune disease mean, right? The immune system attacks the body, right? That's what an autoimmune disease does, right? Attacks the body. So the immune system is attacking its own self, right? And so what occurs here is that the immune system attacks the cells that actually are part of the membranes, the fibrous capsule that makes then cartilage, the articular cartilage, the synovial joints, all of these cells that actually maintain the joint there. The immune system is starting to attack those and destroy those. When you destroy those, then all of those areas, all that cartilage, all that protective factor of a joint starts to go away, right? Usually what accompanies it is joint pain, swelling. We've got an issue with osteoporosis there. We see muscle weakness and cardiovascular problems, right? And why do we see these two in particular? Because the bones play a big role in the cardiovascular system and in muscle. And we'll see that later on when you get into, for example, in the muscle for AMP1, which we are soon to get into in the next chapter. And when you get into the cardiovascular system in AMP2, you'll see why this is the case. Okay, so RA begins with inflammation, right? Begins with inflammation. And the inflammation cells migrate to the joint. Those inflammatory chemicals destroy tissue. We see swelling occurring. The synovial membrane thickens. And then that clings to the articular cartilage. Scar tissue forms. And that scar tissue starts to connect the ends of the bone. And we call that ankylosing process then of connecting from the scar tissue the articulating bones, right? The articulation of the bones. And that's the big issue, because once scar tissue starts to form, it starts to actually seal up, bind joints together. And so when we see that, it eventually will become immovable. That joint will become immovable. And so this is what you see, right? If you notice here, there's a huge amount of swelling here occurring on the joint between the carpals and metacarpals. I'm sorry, the carpal bones here, right? And the carpal bone here. Okay, this joint, if you will, right here, is the ends of those two bones articulating or forming that joint. And what we're seeing here is swelling, and we're also seeing the pannus, that tissue that builds up in the synovial membrane, and in getting replaced from the cartilage is scar tissue, and that scar tissue is actually binding those two bones together. And when those bones bind together, and scar tissue starts binding those together, we see this deformation of the hand. And you can see, for example, I'll erase this so we can see it a little bit better, but you can see then how the fingers are deformed in a certain area, right? So they stay in this kind of formation, right, where the hand starts to kind of deform, and in fact the person's hand stays like that. Okay, so this is a severe form of rheumatoid arthritis, RA, that so much so that the hand will stay in this, locked in this position permanently. Okay. In gouty arthritis, this happens when we deposit uric acid, okay, in the joints, in the soft tissue, And after uric acid gets deposited there, we have an inflammation response, right? I have an inflammation response. Some folks are pre-engineered, pre-designed for this to happen because some of us have the genetics for it. Some of us are predisposed to break down, for example, proteins. So I'll just write pro, but that proteins, right? And we start to metabolize or break down proteins, right? And the process of breaking down proteins releases uric acid, okay? And in breaking down uric acid, and some people break it down more readily than others, that uric acid again gets deposited into the joints and in the soft tissue, right? Inflammation will form, and then we start to see an inflammation response, much like we see in rheumatoid arthritis. And we usually see this indicative, with the great toe. Right, your big toe is where you see gouty arthritis first form. The reason why is because that's the largest joint that you have there in your toes, number one. And number two, it's the area that's furthest away from the heart and the rest of the body. So because of gravity, because of pressures, that uric acid kind of stays locked in to that particular joint. And this is where inflammation will be found. And this is where you'll actually have symptoms forming. So you'll see inflammation in the big toe. And that's usually indicative of gout, right? And so how do you prevent gout, right? Well, you don't really prevent it, but plenty of water, alcohol, and foods high in purines. Purines are a type of protein, right? And so things like liver, kidneys, sardines have purines, high fatty meats, for example, so have contain purines, and those purines get broken down to uric acid in the body. And again, avoiding those can lower your gout. Okay, I want to talk really quick about Lyme disease. Okay, Lyme disease is usually, so it is caused by bacteria. The bacteria is actually transmitted by tick bites, and that's usually what you see Lyme disease causing. And the tick will contain the bacteria inside of itself. When it feeds on your blood, basically by biting through your skin, it deposits the bacteria into your bloodstream, and this is how you get that bacteria. Symptoms include skin rash, flu-like symptoms, foggy thinking, and then that bacteria tends to have a particular type of toxin, and that toxin causes inflammation, and that gets deposited in the joints, right? And really the way you treat Lyme disease is antibiotics. Wanted to mention this because it does lead to acute arthritis. All right, wanted to talk about this. This is the last part of this joint, part B, but about week 8 in embryonic development is when the synovial joints start to form. So we'll see synovial joints starting to form in week 8. Okay. And we'll see this occurring there, right? We'll see this occurring there. And so I wanted to talk about then the other side of things, right? Advancing years, right? And talk about how this OA, this osteoarthritis, some of the effects of the natural process of our body just getting old, right? Ligaments and tendons start to shorten. They start to weaken out. So they get shorter and shorter, and they start to be weakened. Intervertebral discs do the same thing. They actually become shorter and shorter, skinnier and skinnier, and they actually can slip out more easily. And then most people in their 70s, as I mentioned, half of the people in the United States over 85 have OA, but most people already have OA in their 70s. And so it's a good ending of the chapter. Talk about how you can actually have better mobility as you age, right? Well, all comes down to this, right? Unfortunately, for a lot of people, exercise is really, really key, and it's beneficial for a lot of things, but including your joints, right? And looking at your joints, then full range motion, using those joints in exercise, moving them, using that fluid, having that fluid go through in the synovial joint, getting circulation in those areas are really important for postponing joint problems, right? So physical activity is really important throughout your time here, right? Your age, and you'll see this in the joints, right? So not just this, but exercise does a tremendous amount of different other things, but again, just another reason why exercise is really important. Okay, so this is part B of joints, and so if you have any questions on this one, please let me know. I can answer that for you. All right. Thank y'all.